neurology, pathology, idiopathic intracranial hypertension, and hydrocephalus. All right, so for idiopathic intracranial hypertension, it's also known as IIH or pseudotumor cerebri, okay? And all that this is that it's an increase in intracranial pressure that we don't know what causes it, okay? It's just idiopathic. Now, there are certain things that are risk factors that will help you 1,000% get the answer right off first rip, okay? Now, the end all be all, okay? Now, this is not going to be like stark 100% going to get you every single question, but they'll probably get you around 90% of the questions for IIH. If you see a young, obese female with papilledema and headache, put IIH, okay? 100%. IIH, young, obese females with papilledema and headache, okay? That is going to be a classical presentation of IIH, all right? And they will ask it multiple times. I'm telling you, it's like 90% of IIH questions, all right? Very, very straightforward. Sometimes you could get like vision loss that worsens on Valsalva. They could say that as well. But the patient's going to present as a young, obese female with papilledema and headache, all right? Now, there's other risk factors that are also associated besides the female sex and obesity. And one that they like to test on is vitamin A toxicity. So if you see a patient that's presenting with like dry skin, hepatomegaly, and then they have signs of IIH, like that might be papilledema and headache, the answer is probably going to be vitamin A excess, right? Because vitamin A excess is going to show as like dry skin, and it has some liver involvement with hepatosplenomegaly, or hepatomegaly, not splenomegaly, just hepatomegaly, all right? So keep that in the back of your mind when doing IIH questions. Once again, majority of the time it's going to be young obese females with papilledema and headache, but they can use vitamin A like toxicity as one of the causes of IIH, and I've seen that occur. All right, you're going to see papilledema once again because you're going to have, that's just one of the signs of increased intracranial pressure. So that's classic to be seen. Now, the way that you treat it is one, weight loss, and two, acetazolamide. I don't know if you remember in the sketchy videos, but acetazolamide was used to treat pseudotumor cerebri. It's the same thing, all right? It's just another word for idiopathic intracranial hypertension, all right? Next is hydrocephalus, all right? Hydrocephalus just means that you have increased amount of cerebrospinal fluid. Okay, so increased amount of CSF volume is going to tell you that you have hydrocephalus. Okay, that's kind of how they differentiate it. That's how they define it, I should say. All right, now that can lead to ventricular dilation majority of the time. All right, and so there's two different types that I really care about: the communicating versus non-communicating. Communicating hydrocephalus means that there's no obstruction. Okay, so that means that all the ventricles are continuously in communication with one another. There's no blockage, all right? And we know, based off of the anatomy of the ventricles, that it starts as lateral, then it goes through Monroe to third, and then from third it goes through the aqueduct to fourth, all right? So when all of those are still connected to one another and there's no obstruction that's blocking any of those regions, you know that it's communicating, all right? Now, one common cause of communicating hydrocephalus is decrease in the CSF absorption, all right? And decrease in CSF absorption occurs at the arachnoid granulations, okay? So communicating hydrocephalus is going to be shown as all ventricles are dilated, and it can be kind of like a common sequelae of meningitis, and it's also caused by arachnoid hemorrhaging. Okay, so keep that in the back of your mind for communicating hydrocephalus. It's going to cause all ventricles to be dilated because it's communicating, and it's due to the fact that you have a decrease in CSF absorption from the arachnoid granules or granulations, all right? And it can be probably a common sequelae of meningitis. So it's usually like scarring due to meningitis. After meningitis, you can see communicating hydrocephalus, all right? Next is normal pressure hydrocephalus. For normal pressure hydrocephalus, I'm going to give you a fast and easy way, just like IIH. There's a fast and easy way to identify normal pressure hydrocephalus in a patient, okay? This is what it is. Wet, wobbly, and wacky, all right? Wet, wobbly, and wacky. It's very, very straightforward, all right? And what does that mean? That means that the patient's going to present with some type of gait ataxia. So they're going to have some type of difficulty walking. They're going to have some abnormality in their cognitive function, so cognitive dysfunction, and they're also going to have urinary dysfunction or urinary incontinence. All those together is going to show me a common photo for normal pressure hydrocephalus, all right? You're going to see the expansions of all the ventricles, okay? And that leads to distortion or distorting the fibers of the corona radiata. They love that question. So normal pressure hydrocephalus is caused by the ventricles expanding, leading to distortion of the fibers of the corona radiata. All right, so keep that in the back of your head. That is a question that they like to ask about. All right, and the patient's going to present, once again, if you ever see a patient that has urinary incontinence with cognitive dysfunction and abnormality, and they're wobbly, they're unable to walk correctly, that is the classic triad of normal pressure hydrocephalus. And they give you all three every single time, okay? It's very easy, very straightforward, and it's due to the fact that you have distortion of the fibers or the corona radiata, okay? So don't get that wrong ever. It's wet, wacky, wobbly, all right? Or wet, wobbly, wacky, or whatever way you want to talk about it. But all three of those are very key. The symptoms will always be there for you, all right? Next is non-communicating hydrocephalus or obstructive hydrocephalus. This is very easy, right? That means that there's some type of obstruction that's going to lead to asymmetric dilation of the ventricles, right? So it's going to be a structural blockage of the CSF circulation, all right? So it could be a blockage within, near the aqueduct, right? Between third and fourth, or it could be blocking the foramen of Monroe due to a tumor. But all in all, that's obstructing. And the patient is going to present with papilledema, headache, and vomiting, okay? Now, that's all you really need to know is that there's going to be an obstruction there and the ventricles are going to be asymmetrically dilated, all right? Next will be hydrocephalus mimics. So although it's not actually hydrocephalus, it looks like there's a dilation of ventricles or an increase in CSF volume, and that's ex vaccio ventriculomegaly, all right? And we already discussed this in the previous chapter. Whenever you see ex vaccio ventriculomegaly, it's talking about the fact that it appears that there's increased CSF on imaging, but in reality, there's just decrease in brain tissue. And when you have decrease in brain tissue, the ventricles look larger, right? So it's due to significant neuronal loss, and it can be due to, once again, AIDS that can cause the HIV-associated dementia, okay? That's one major cause of ex vaccio ventriculomegaly, okay? Now, you're going to see normal intracranial pressure for patients that have ex vaccio ventriculomegaly, okay? And that's going to be the key differentiator, right? And the reason behind that, once again, is because you genuinely don't have an increase in CSF. It's just the fact that you have loss of brain tissue that makes it look like you have ventriculomegaly. So you have normal intracranial pressure, all right? The last one is congenital hydrocephalus. And I like to break it down into just three things. The first thing, you're going to see macrocephaly and poor feeding. So if a baby has a very large head and they have poor feeding, that's the first sign of congenital hydrocephalus. Once again, you're going to see on imaging enlarged ventricles. That's the second sign for congenital hydrocephalus. And the third sign is that it could potentially lead to developmental delay, poor growth, and muscle spasticity. If you see muscle spasticity with large head and enlarged ventricles, that's poor feeding baby, poor growing baby. Muscle spasticity is going to be very key to helping you differentiate from anything else compared to congenital hydrocephalus. All right, so that's all for IIH and hydrocephalus. Once again, keep in mind the normal pressure hydrocephalus is very, very high yield along with idiopathic intracranial hypertension. And they're very easy to differentiate. Once again, IIH has a young obese female with papilledema and headache, boom, all right? And then for normal pressure hydrocephalus, this is wet, wobbly, and wacky, all right? Just keep those straight and you should be relatively fine for these questions.